Welcome back to The Short Coat. Coming to you from the amazing... Wait, I want to do this. Welcome back to The Short Coat. Coming to you from the amazing and intense world of med school at the University of Iowa, Carver College of Medicine. I'm Dave Etler. And it's a new year. We've been taking a break for the last few weeks. So if you've been waiting for us to come back, I'm so sorry. But, I had nobody to be on a podcast with, and nobody wants to listen to me on my own.
I would have listened to you, Dave.
Oh, that's sweet.
Zach and I were talking about it last night in bed. We were like,
I was like, whoa.
Yeah, we were like,
Zach, your husband.
Yes.
Not
Yeah.
Zach,
Oh,
not Zach, the podcaster.
I'm so sorry.
I was like, no, it's my first time.
Crazy.
You're not used to there being another Zach.
Yeah, no, we were like, remember a few years ago we were in the van and like all we used to do was listen to Dave. That was it. We just listened to Dave.
That's up.
Yeah.
Good.
Yeah.
You guys know that she and her husband
Other Zach.
then boyfriend traveled the world traveled the country in a van for years.
Yes.
And
Yeah.
and I knew you only on Instagram.
Yeah,
Or whatever.
And anyway, we listen to you all the time. So
Well, here I'm back. We're back. This week was Transition to Clerkships Week, where CCOM works to give our M2 students the sort of big picture, I think, introduction to how a student of clinical medicine is, how to be a student of clinical medicine. I'm so good at my job. And we thought we'd talk about that. To help me with this kind of abrupt change from classroom to practical, I'm joined, as always, by my medical student co-hosts, like M2 Alexis Baker.
Hello.
And M2 Samantha Gardner.
Hello.
We've got M3 Zach Case.
Hello.
And we've got M3 Fallon Jung.
hello.
So Alexis, Samantha, you guys will be starting your rotations Monday. Fallon, Zach, like I said, you're a year into clinical rotations, specifically what we call your core year. Generally, the clerkships CCOM has decided are, I guess, best to start with. A lot of primary care, psychiatry, OB, things like that. So, Alexis and Samantha, what's your first clerkship?
We are both on psychiatry.
Okay.
And so my understanding of what's happening Monday is like what's happened all week, where it's just an orientation. So like 8:30 to 4:30 of just orienting us to what the rotation is going to be.
Mm-hmm.
There's like some lectures. There's like a neuroanatomy for psychiatry.
Are you nervous?
For Monday, no. For Tuesday, yes.
Yeah. What are you most worried about, do you think?
I don't know what I'm supposed to do.
Yeah. Well, they told you.
I mean, kind of. One of the people leading a small group, I looked at and said, so on Tuesday, when I walk in, am I just supposed to say, hi, my name is Samantha. I'm an M2. Today is my first day of my first rotation. What do? And she said yes. So
Yeah.
I guess that's what I'm going to do. But I feel a little bit like the guy in Up when he's like, my name's Russell and I'm a wilderness explorer. Do you need any assistance today? Like, I don't know what I'm going to do for you, but I'm here.
And whoever you say that to will be like, oh shit. Well, I don't know. Maybe are they happy to see a new medical student?
I started on surgery, and so I think it's maybe
Hard
a
to
little
say.
different.
Yeah, usually happy.
Like
Yeah.
they weren't mean by any means.
No.
Sure.
Always
I-
welcoming.
Yeah, but nobody was like, ha ha, so happy you're here.
Unless you're on peds, then maybe.
Yeah, I know our friend that starts on peds, they're doing like an escape room together before the rotation.
Like,
I was like, wait, like
all the
like-
staff?
no, like the students starting on peds.
Oh.
Oh.
I don't know who is organizing this, if it's just the clerkship coordinator.
That
But I
sounds
was
fun.
like, I want to do an escape room.
Yeah.
We're
did
not
do
doing
an
that.
escape room.
No, we didn't do anything before.
We have a return of Dr. Sipla, who is going to give us an hour of neuroanatomy, and I will probably be in tears at the end.
It was
So
pretty
we will
fun.
not be.
Yeah, maybe it'll be different. Maybe it'll be.
Yeah, maybe.
Yeah. So, for the more experienced students, what is the role of the clerkship student? Like, can you go through almost a day in the life, maybe, of a clerkship student? What are you supposed to do?
I feel like typically they will assign you 1 or 2 patients. I guess it depends too if you're in clinic or on inpatient. But we'll start with inpatient because that's probably what you're less familiar with. So they'll give you a patient or 2. You'll pre-round on them, look at the chart, see what their labs are, what they're there for. Go see the patient. And I think most of the time for me, I would just talk to them, see how they're doing, and then do a quick like physical exam. And then that's kind of it for the morning until rounds start. And then you present your patient.
So you're like, hey, what? So, hi, my name is Zach. I'm a med student. What are you here for today?
Yeah. Or like if you have pre-rounded, you'll probably see like why they're in the hospital. And so it's kind of just checking in a lot of the time.
For inpatient.
For
it's a little
inpatient,
different,
yeah. And also like this is later down. Like when I first started, I think I just shadowed the first day for the most part. But,
Great.
yeah. Which was really nice. Yeah. But that's, and then, you know, round with the team, and that's kind of it until they tell you to do stuff. And then it's kind of just see what comes up.
Yeah, if something happens during the day. But the nice thing about inpatient is that, like, after you finish rounds in the morning, unless something comes up, nothing really is going on. So, like, you can finish up your notes. You can, you know, go back and see your patient again. You can kind of, like, just do your thing.
Yeah.
Study a little bit, maybe.
A lot of talking with the team, or the team will talk about what they're doing, and you'll just kind of listen most of the time.
Is there a role really for the student in the team? Because it's, I mean, to hear you say it, it's like, oh, I'm going to go chat with a patient, and then I'm going to, like, you know, that's it, pretty much. But what's the med student's role?
You're the person that has the most time to be with the patient and like the most time to kind of connect with them socially, which is something that a lot of patients don't really get in the hospital. And especially on what you guys are starting on, it's just like a little bit different because it's an open ward. So like people are kind of like out and about and doing things. And so you can really just kind of like go in there and like get to know them a little bit. Like, and a lot of the times, particularly on what you guys are starting on, like patients are pretty medically stable. A lot of patients are waiting for placement. And so you guys are able to sort of just like play cards or like participate in like some of like the recreational things and like kind of understand what the struggles are throughout the day, and how you can sort of mitigate that kind of stuff, where your residents and your attendings have a lot of stuff. Like they have to deal with all sorts of people, but you maybe only have to deal with 1 or 2 people. So it just gives you a lot of freedom to get to know people, which is nice.
Yeah, definitely. That is kind of your role, is to get to know your 1 to 2 patients, maybe 3 by the end of core year, and update them on things that come up. A lot of times the residents will kind of delegate some of the tasks to you for those patients too, and be like, can you go let them know XYZ? So, and that's kind of fun too. Just once you have a rapport with them, you kind of get to take part in telling them what's going on and explaining stuff. So, yeah.
What about in clinic rotation? Talked about mostly about inpatient rotation so far.
In clinic, it's a little bit more busy because there are like scheduled appointments all day long from 8 to 5, except for lunchtime, which is nice. And basically, you're kind of like a helper, I'd say. So, you know, maybe you what I tend to do is I reach out to doctors and I'm like, hey, I see that you have, you know, this many patients. Either I'm particularly interested in this thing. Would you mind if I saw, you know, at least this patient today? Or are there any patients that you would like me to see? And that allows you to kind of like look them up if you want and prep for that patient's appointment and kind of see what's been going on with them. And then you just kind of go see them, and it's almost like you're living the world of your OSCE in real life. And yeah, and then you write the note, and often your doctor will your doctor always comes in. Sorry, my bad. Your doctor always comes in and it's like, all right, you know, like like now the student might present to me right now, so like, just feel free to jump in, that kind of thing. And then you do the plan and you send them on their merry way, and then you write the note. Sorry.
Yes.
Yeah.
Yeah. It's very dependent on like who you're working with too. Like some doctors like to do clinic differently. There was one when I was on neuro, provider who made me see like all the patients that day in clinic. So that was a lot. I didn't write notes, which was nice.
Ooh.
So it was more just talking to people and before she went in. But yeah, it kind of depends on how many patients you'll see. It depends on the provider and that kind of thing. But I actually really liked clinic. I wasn't expecting to, but I did.
Yeah.
Mm-hmm.
It's the fast pace of it, or the
I think also just like talking to people was more, not that I don't like talking to people, but it was more fun than I thought to just kind of sit down, meet someone you've never met before, and just talk about whatever. Like, because a lot of times you'll talk about what they're there for, and then you'll go off on a tangent for 30 seconds to a minute and learn something about them.
I did want to ask a question. So when you guys are writing notes, I feel like I see online, like people joke, like you write your note and then they just delete it. If you're the med student, do they actually use your note, or are they writing their own notes separate, or?
Maybe if you write like a really shitty note, they might delete it.
Okay.
But but for the most part, like, I think if you've done the work of looking at how they write their previous note, a lot of people copy forward the old note and then just like update, or like they'll put in they'll have the old HPI and you put in an interval history, which is basically like your own HPI. And as long as you're thorough, I don't know that I've really had very many problems with that.
Yeah.
Yes, I feel like your job, you correct me if I'm wrong, when I write MSPEs, I've seen a lot of comments that are like, she writes a good note. And I'm sure that in those cases, they've looked over your copy forwarded note, and then they've either elected to use it or use some of it, or, change it or whatever. And then hopefully they give you feedback on your note. Does that happen?
Yeah, usually. Yeah.
Okay.
There's also like a little thing on Epic where you can see who wrote what, and you can so basically they're like, if 3 people wrote something, the resident, you, and the attending, and you unclick yourself and you unclick the resident, you can see just what the attending wrote, or vice versa. And you can see basically how much they added or how much they like have deleted from your note too.
So you're basically like, first of all, taking your cue from what other people have done before you with this, or with patients.
Yeah.
And just sort of mimicking that. So that doesn't sound too bad.
Yeah. There's a lot of templates too that they use. And so like, if you just follow the template, a lot of time it's what they want anyway. So especially with progress notes, if you just copy forward, there's a lot of times where residents changed either nothing or very little in my note. So, and I think that's just like, a progress note is really just a short, quick update about what happened that day. And so there's not much to it, but.
How much time do you spend writing notes in the beginning?
Ooh.
I'm kind of a slow note writer, so I don't know that I'm the best person to ask.
I feel like I'm the opposite end. I feel like I write my notes quick, sometimes too quick, but not
Great.
too quick.
Yeah. I mean, you probably shouldn't spend more than 2 hours on a note. That's really too much.
2 hours on one note?
That's really way too
That is-
much.
I don't think I've ever
I've spent up to an hour on a note before, though.
Uh-huh.
Like if a patient is really
super
complex.
complicated, yeah.
Yes. A brand new clinic patient that's very complex could take an hour. Progress notes on inpatient.
Oh, yeah.
When I first started in internal medicine, I would take, like 30, 40 minutes to write a progress note, because I would scan through everything, be like, I need to make sure that every detail is right. By the end of core year, after getting feedback from residents for a whole year, I would spend maybe 10 minutes on a progress note tops, and then be like, send it to, because you always send your notes to the residents so they look at them before anything happens, and send it to them, and they would be like, yeah, that looks good. Like progress notes are quick. Clinic notes can take longer.
Yeah. I wrote a lot of clinic. I think I'm thinking mostly about clinic notes and like the HPIs. So like when a new patient, even like on
It's the history of the
comes
present
in.
illness.
Yes. Yeah. So like the H&Ps. Damn it, that's what they're called. I always get confused.
Wait,
History and physical.
History and physical.
Yeah,
okay.
those are the H&Ps are like when a new patient comes on inpatient and you have to like do like the admitting note basically for your floor.
Yeah.
And HPI is just like the subjective of any note. They sound very similar. So
It's okay.
And you guys both said like copy forward. How do you do that?
there's a little button.
Okay.
We can show you.
Yes. And the residents will probably also show you.
Okay.
Yeah.
Because they also typically like when you copy
Yeah.
forward.
You saw a lot of things over Transitions Week. I know this is one of the things they pointed out, and I'm like, and they were like, you're never going to remember this, but this is just a familiarization kind of situation. I happened to come in when they were doing that particular thing, and looking at the screen that they were showing us, it looked like crazy talk to me. So I get why, like, you're going to have to see this a couple of times before this particular.
Well, the Epic training is just like videos, and they're like mildly interactive. Like it'll pause and tell you to click somewhere, and you've been like on the New York Times doing your Stoku the whole time, so you don't actually know.
Okay,
where it
now
told
we're
you to
telling
click.
secrets.
And so then you just have to like click somewhere else, and it'll point out to you where the button was that you were actually supposed to click. But like you're just kind of watching a video, and that's just not how you learn
Yeah.
a computer system.
Yeah, you got to
So-
learn it.
I agree.
I can't look at a video. I mean, I can look at a video, and that gives me like, okay, now I kind of know what's going on, and then
Yeah.
I have to actually do it.
Yeah,
to
like
make it
you can
happen.
get maybe some like hot tips out of a video,
Mhm.
like a feature that you might not use right away if they say it once. Like, great, now it's in your head, but just the general, like you're gonna do this. A video is not the way I'm
Yeah.
going to learn that. So
Are there times when it isn't clear what you should be doing,
Yeah.
and what do you
What do you do?
do in that situation?
You just ruminate in it. You just sit and you marinate in the uncertainty.
Yeah.
You don't ask.
Well, every once in a while, like, yeah, of course you
You
ask.
ruminate in the uncertainty.
Yes, you ask.
Life.
You base yourself later. I'm just marinating.
Yeah. I'll taste good later.
honestly, though, who among us has not shadowed in a clinic and the attending just has to go somewhere and do something that you're not part of, and you just sit for 30 minutes in a corner in a room. Maybe a nurse comes in and asks you who you are. Maybe they don't, but you just sit.
And you're
so
like, can I
I'm-
look
And
at
you're
my
like-
phone?
Yeah.
Or
Have I been forgotten?
Like if I go to the bathroom right now, is that going to inconvenience somebody if they come in looking for me and I'm gone? So I'm anticipating a lot of that.
It's
is
not a
that-
lot. I think it's a mild to moderate amount.
Yeah, I'd agree. with that.
Particularly in the beginning, it's more moderate.
Yes.
Yeah, I feel like they told us to over communicate and be like, oh, is there anything I should do? And is it okay to study? But I feel like if there's a lot of downtime, it's going to be annoying if like I've finished what I need to do and keep asking if I can study, and then they pull me away, and then I'm like, oh, can I study again? And like,
I think it's better to say, hey, I've done these things. Is there anything else you need me to do right now? And if not, I am going to study. I think that at some point people get really frustrated. I think like a lot of residents get really frustrated when you're constantly asking like, can I study? Can I study?
yeah, that's
Can
what I
I
was
study?
thinking.
And if you've gotten every single thing done that you need to get done, and they say, hey, I don't need you to do anything else, then that's kind of how I feel about it. But maybe that's more of like a later in courier tip. Maybe you should ask in the beginning. I'm not sure. What are your thoughts, Zach?
I feel like I didn't typically ask if I could study. I would though, like if once I finished a note. I mean, you send the note to them so they see it usually, but I would be like, hey, finish the note on this patient. Anything you need me to like update them on, or whatever else. A lot of times they'll say, no, I'll take a look at the note and get back to you. And you're like, okay, cool. And then you kind of just sit. And I would pull up UWorld on the computer and just study. I wouldn't go on my phone, but
Yeah, don't go.
just on the computer and kind of do that. And then a lot of times if something comes up, they'll just like tell you and ask you to do something. So
Yeah. For a little while in the beginning, I had like a book with me that I'd study from. And sometimes that just made me feel like a little more comfortable. Like I wasn't like screwing around and I was like learning things, but you're still learning things on UWorld. So
yeah, I know for me, I felt like I didn't study very well when I was sitting in like the team room with the residents and stuff, just because I was like, I don't know, always
Angsty.
anxious. Like,
Yeah,
is
you're like
someone
someone's
looking over my
watching
shoulder?
me. Yeah.
I feel like we need to get over this
Yeah.
situation as a society here, because our phones have become like, it used to be that, I mean, yes, your phone can be used to like, scroll TikTok or whatever. But I don't think that's what most people are doing. Is it? Okay. Yeah. Okay.
I am.
But on a rotation when you need to study.
On a rotation,
Like,
when I need to study, I'm
you would
using my laptop,
probably be
TBH.
studying.
If,
Yeah,
I'm,
but-
if I'm on my phone, I'm texting somebody.
Okay,
I'm screwing
alright.
around. Yeah.
It's
Or
just
they are
so easy to go from like, oh, I'm doing your world on my phone, and then you get a notification from like
Yeah.
Instagram, and you're like, ooh, what's this?
Yeah.
Yeah,
That's what I found.
That's a
at
good
least.
point.
Yeah.
Yeah. Yeah. I think also medicine is like such an antiquated profession in the first place. Like it's very hierarchical. It's like, it's just a little bit old school.
Things change slowly.
Things change slowly, so use your laptop.
Yeah, they told us a story of somebody getting in trouble for being on their phone, and they were like quite literally on Epic looking up somebody's labs, like for the people who were talking. So the tip we got was like always have your phone tilted,
go like this.
so that
So that
people
they
can
can
see
see.
what you're doing, so they know
I
if
did
you
that in the
are.
beginning. You should do that in the beginning, and then eventually people
You'll
will
get-
start to trust you.
You'll get the vibe also, like, is this cool or not?
Yes, you definitely will. On
But also
rounds.
like be prepared, I think, is also like a good
Mhm.
like don't use your phone for everything, but like if the labs aren't back yet and you're already rounding, then like it's okay. But I might also verbally say like just checking my phone for Epic to see if these labs are back. Like,
Announce what you are doing.
correct.
Yeah.
Show your screen.
Yeah.
Your phone is now communal.
Interesting. I think one of the more concerning tasks for a new clerkship student might be coming up with a plan for a patient. Is that a thing? Yeah, I mean, obviously, you're not expected to do that on day one, but at some point, in any clerkship, even your first one, you're expected to take a stab at a plan. How was that in the beginning?
I always found that to be hard starting out. Just because you like when you first start, at least I was just scared that I was going to be wrong and like say something that like was dumb. They're
Yeah.
gonna be like, why'd you even think that? But that doesn't happen really. It's not the case. But yeah, I felt like I also didn't really start saying plans on presentations until later on in core year. Or maybe I would mention like one thing or two things that were like really basic, and they'd be like, okay, yeah, sounds good. And then a lot of times they'll talk with the resident about what they actually
The real
do.
plan.
Well, I feel like in preclinicals, you aren't really learning how to make a plan.
Mhm.
They'll say, like, you give this antibiotic, but there's no dosing, learning of antibiotics in preclinicals or
Yeah.
any medication, really. They give you a lot of options, but not, like, a ton of information about why you would choose each option. So I feel like you aren't really set up for
Mhm.
giving
You don't know any
a
of that
great
shit. You don't know any of
plan.
that shit yet. Yeah, like
Yeah, we don't know dosing really.
No, I never said dosing in a plan. I'd be like, they should start Bactrim.
Yeah.
That was
Great.
it. Yeah.
I think also like if you're doing a progress note and there's a plan for somebody, like if you copy for the progress note, likely there's a plan from yesterday that's pretty up to date, right? And you can kind of fill in the, well, their calcium is now back down to normal, so we don't have to do anything about that. So I think that's pretty helpful. And I think the other thing is if somebody's really urging you to do a plan and you're like, oh, I don't know what to do, like just start with the basics and be like, well, I think they have an infection, so we should probably give them an antibiotic. Also, I'm a little worried that they might need surgery. Maybe we should make sure that they're hydrated, but are NPO or something, or don't eat anything, right? Just the most very basic things are they have a headache. Can we give them something for their headache? Something like that.
Yeah, one of the small groups, they're like, if you are inpatient and you bring up pain, poop, and DVT prophylaxis, that's just remember that.
Yeah, seriously though.
we're going to take a quick break. We'll be right back in just a second on the Short Code Podcast.
Ooh.
I'm told, Fallon,
Uh-huh.
that people love to watch videos of podcasts. Do you watch videos of podcasts?
I don't, Dave.
Does anybody watch videos of podcasts?
God, no.
Nope.
No.
Well, everyone says it's a thing. And I give people what they freaking want.
Who is everyone?
I don't know. Maybe they work for freaking YouTube.
The one person.
The people who work for YouTube, the people who work for Spotify. I don't know. So I'm just, I give
Are people
what they
watching
want.
the video on Spotify? That's
Do people know what we look like?
I think, yeah. Some people. So look, we're on YouTube. Our Spotify episodes also feature video, although sometimes the video version is delayed from the audio version because Spotify is annoying that way. Anyway, if you want to watch people having a conversation, if that floats your dinghy, then who am I to judge? Plus, there are things that you can see that you can't see with your ears. That's just a medical fact.
I'll bring that
Not
up.
the truth.
Yeah.
Yeah.
add that to my plan.
Yeah. Assessment.
There
Yeah.
are some things that you just can't see with your ears, right?
Yeah. So look us up or look in the show notes for links, okay? All right. You guys have spent the last 18 months in the didactic world with some intermittent exposure to something approximating clinical medicine, like your early clinical experiences, things like that. Now it's time to really sort of immerse yourself in hospital culture and the new sort of social dynamics and professional expectations that come with that. Of course, you're sort of trying to learn, but you're also trying to get good evaluations from residents and attendings because you know that they'll influence something, maybe how future residency programs will see you. So I thought we'd talk about some of the social aspects of this in this core year. And one of the questions I have is like rounds, which is a very social thing in my mind. Like you stand in a group of people. In my mind, you stand in a group of like what? 5 people, 10 people,
Sometimes
40 people.
Like, yeah, right. It really depends. Anywhere from 2 to 40 people. Correct.
I have a vague idea of what this looks like in my head, maybe from television shows. I don't know. Talking about patients. Tell me about this experience. Like, what is it like?
Rounds. You either like them or you don't. I don't think anybody feels like, rounds are fine. Do you feel like? Yeah.
I don't know. They're pretty polarizing.
Yeah.
Why?
I don't know,
They're
honestly.
so basically what you do is you go around and you see every single patient in the morning with the team. And most of these patients are not your patient, right? Because you maybe have 1, possibly 2 people. And so you listen to usually the resident give, sort of their
Spiel.
thank you, about the patient, talk about the plan, you go in, you chit chat with the patient, and then you leave. However, they can become rather long and drawn out. And it is imperative that you at least look enthralled.
Let's practice our enthralled faces. How about this?
That's good.
Yeah.
What if you did this
It's
Yep.
the whole time.
during
Somebody would
rounds?
be like, do you have
With the
acid
arm?
reflux? Are you choking?
Are you having a heart attack?
the universal choking sign?
Dave on rounds. Tell me more.
Oh man. Anyway, but yeah, I think like the big thing about rounds is just like look interested, try to find something that you can learn because like they're happening regardless. One thing that I liked to do during rounds, TBH, is like this is kind of a secret, but I would like tighten my core and then I'd release it and then I'd tighten my core and then I felt like I was getting a little ab workout in. If I was standing in the back, I'd do calf raises.
Oh.
Yeah. So
The calf
I'd
raises
also
is
do
a
that
good
during
one.
surgery.
She just
if
like
it was
does a
really
burpee mid conversation.
The abs, I'm not going to lie, reminds me a little bit of the early 2000s bad diet culture when my mom would tell me that if I wanted tighter abs, I could just like stand there
Yeah.
and tighten and release.
Oh, I didn't know that.
Oh, yeah.
You're supposed whatever you're doing, you're
Now I'm
supposed to
doing
be
it right now.
you're supposed to be exercising your friggin' abs.
Yeah. She was
I'm,
like,
like,
if you
thinking
just
about
hold
it.
them tight all the time, they'll get tighter.
Well, you're just standing there most of the time. The other thing I'd work on is like my posture, and then I'd see how many rooms I could go before I realized that my posture was bad again.
Nice. So basically, play games with yourself.
Yeah.
Workout games.
Workout
Yeah.
games. I found rounds to be pretty boring for the most part, personally.
I mean, I imagine you're saying the same things kind of over and or you're hearing the same things over and over again, just with variations per patient, right?
Yeah.
I mean,
And sometimes depending on what team you're on, like the conversation would go down a rabbit hole of like debating one antibiotic versus another. And it's just like over my head a little bit at that point.
Like,
And I'm
all right.
I don't know. I don't think this is going to be
I
on
will
my
pay
shelf.
you people any amount of money if we could move on.
Just pick one.
So I found them difficult, but
Are you expected to contribute sometimes?
yes, when it's your patient that comes up, you'll give your presentation. A lot of times they'll ask a follow-up question or two. And then honestly, sometimes, especially once you get more comfortable or get to know your patient, like the resident and attending will talk about the plan. And if they ask like, oh, well, like what was their potassium yesterday? If you know it, you can speak up. It's kind of fun. You're like, ooh, I knew that.
You should.
But
That's when
always
you're like,
get
let
the
me look
trend.
that up on Epic.
Yeah.
Yeah, straight up, always know the trend. Like they're gonna have you like write down the labs and stuff for your patient. They do not care if like the potassium's 4 today. They want to know if it was 3 or 5 yesterday, and 4 today. So just always know the trend.
Yeah. And if you've been following them for a while, it's kind of like you already kind of know it because you've been writing it down every day for the past week or something. So,
But that's a hot tip. Always know the trend.
What's the earliest you got to pre-round?
So pre-rounding.
5:04 a.m.
So I learned this week that pre-rounding is when you basically go in and then look up your patients
Yes,
that you have, right?
and then you go bother them in bed.
Yeah, you're like, hey, you were sleeping soundly.
yeah.
Perhaps for the first time since you've been here. Tell me all of your stories.
Are you in pain? I know that you just had abdominal surgery yesterday.
Yeah. And also, did you poop or fart recently?
Yeah. Very important.
I guess when you're like pre-charting, and because I've heard people say that they do it the night before, which means that you're opening up Epic at home and like probably writing down like physical health information about your patient at home. How anxious are you about having to transport that written down in
Literally
your car,
not
and
at
that
all.
somebody is going to like break in and you are going to be fired for HIPAA violation?
Just don't.
Yeah. I just
Yeah.
put it in my backpack and zipped it up.
Yeah,
Okay.
yeah. Just like make sure it's in your folder or
Take
like
reasonable precautions.
Yeah.
right. Yeah,
Yeah.
but yeah, don't be a crazy person. Like don't like just like I don't know. Don't wave it around and be
Give
like,
everybody-
this is so and so's information.
Give every patient code names.
You can also just write like their initials and then like
Yeah.
the number as their age, and you don't have to put year old after it. So then it's like, what is this mysterious number? I don't know.
Yeah.
So,
Did
Well,
you guys
now
always?
you've told everybody.
that is true. Now
That's
everyone
true.
knows.
Did you guys always do your pre-rounding the night before, or would you go
Never.
in the morning?
Almost
okay.
never.
Yeah. I think I did maybe once or twice
Okay.
on
Yeah.
surgery.
I
That's
thought
it.
about it and then I was sort of like, but what if important information comes up in the morning?
See, that's what I was thinking about.
Yeah.
And also,
Yeah.
like, there is a performative aspect of like showing up at the hospital
Yeah.
maybe and like being there at some ungodly hour for surgery.
Yeah.
Mhm.
But honestly, like 5:04 was the earliest I ever got there. So
5:30 for me. Yeah. Which I think I partly got lucky on surgery because I know some people in my class got there earlier. But
yeah.
I've
I
heard
think-
burns is bad.
Oh, I don't
Mhm.
know. I didn't. Burns are bad, but I
Traditionally.
traditionally burns are
Yeah.
bad. They smart. Ooh.
Yeah.
Yeah.
That's a medical fact right there from a senior medical student. I want to talk about the very famous pimping topic thing that I think a lot of people might worry about. Did that happen often?
Honestly, not as much as I thought.
yeah. Yeah.
Like
This is
pimping,
true.
okay, so for the uninitiated, like Audra back there.
What? What are you doing? Why are we sending him to the hospital? No.
Pimping is as I understand it, pimping is the what senior doctors will do for medical students, where they will ask them questions that maybe they don't quite expect you to know the answer to.
Not to be confused with actual human trafficking.
Yeah, this is not a
Yeah,
human.
why
Important
do
distinction.
we call it pimping? That is strange. I didn't consider that until we just had this conversation right now.
So they're asking you questions, and it's basically like some people think it's like I want to catch you out on not knowing something that I really feel like some esoteric piece of knowledge that I, I don't know. It stands for put in my place. That's although that might be a backronym. I don't know.
Oh,
I think
Never
it's a
heard.
acronym. I've never heard of that before either, but I can figure out what it means. How interesting.
I mean, at its core, it's supposed to be the Socratic method. I'm asking you questions in front of everybody so that we may all learn together. But I think maybe in previous eras, it was more common for it to be like, I'm asking you questions to embarrass you for not knowing something so that you will, feel shitty and go and fix that.
That was my experience was less of the latter and more of the they're just asking you because I want to see what you know.
Yeah.
Yeah.
And like what they can teach you.
I think the hardest thing about clerkships is, or one of the harder things about clerkships for some people is trying to show what you know.
Yeah.
And if you're a quiet person, you kind of can get dinged for that in comments a little bit. Like they're quiet. Like I feel like she knew a lot of things, but she was also quiet, and I'm not really sure. Kind of comments, and I don't know how to change that. I don't know how to fix the students' communication style so that they're comfortable talking when they don't know shit.
I'll be honest, like I will say that this is definitely coming from a biased place where like I am a talker, but at the same time, we don't really know how to communicate with other people except through, verbal stuff and I guess like a little bit of body language, but you're not telling people that you know about like certain parts of the brain when you do this, right? Anyway, so like I think a lot of courier is getting out of your comfort zone, and if being quiet is one of those things that like, or I guess being more talkative is something that like gets you out of your comfort zone,
Kind of got to do it.
stretch.
Yeah.
Mm-hmm. Yeah, presentations sometimes they'll ask you questions after your presentation. So if you do know the answer, that's always a good place to shine if you aren't chatty. Then if you don't know the answer, that always kind of stinks, but it's never that big of a deal, honestly.
I do think maybe we as a society have oversold medicine as like a quote unquote smart people profession when really it's like a talking profession.
Yeah.
Like a lot of the job is talking to your patient and talking to your team. And we sell it as if you're smart, this is for you. When like, yeah, it's hard, but also you do have to talk whether you want to or not, unless you're maybe in pathology or radiology. But I presume there is still talking involved somewhere.
Just into their dictation.
Yes.
The perception of radiologists and pathologists, they're like monks with their like, hoods and they never speak.
In silence. But I presume those people still have to talk to somebody somewhere along the line. So I think maybe we need to be pushing that there's talking a little bit earlier along down the line.
What's hilarious to me is at one point during one of the presentations this week that I attended, they were doing the Socratic thing with you guys, and it was really hard to get you guys to talk.
Oh, I did hear that you guys are a quiet class.
That came from Bill.
That's because if you say the wrong thing, everybody roasts you.
What?
Yes.
Oh,
That's toxic.
Good to know.
Also, I feel like in lectures, a lot of our classes just like on their laptops or something, so they're not.
Yeah.
Oh my God.
But we
what
had
do you mean
Zoom
by they
issues
roast
like
you?
a year ago where somebody would like ask a question or say an answer, and people in the chat on Zoom would like go in and tell them why they were wrong and shouldn't be saying that.
Oh no.
So in general, I'm a person who thinks I did a lot of band. And so in band, they tell you to like, if you're going to be wrong loudly, like play with confidence. And if you played the wrong note, you played the wrong note. That is no longer my strategy. I am wrong in the group chat and I am silent in the big group chat.
Oh my
Wow.
gosh.
no, I don't like that.
I don't like that either. Highly suggest actually, like, if you're gonna be wrong on clinicals, like,
I feel like
wrong
you.
now.
Yeah, I feel like it'll be
feel
better
it-
when you're like in the smaller groups
Yes.
and not the entire.
It
And
is
with
hard
people
in
who
a
are there
big
to
class.
teach you and not with people who are
Yeah.
trying to claw
And it's
to the top.
It's
but
definitely worse if an attending asks you a question and you just kind of sit there quietly for a few seconds and then just whisper, I don't know. Than if you like give like a some type of answer, even if it's wrong. At least you
Yeah,
said
I
something.
do know, but
Yeah. Yeah.
Or just like that, you know what? That was a really good question.
Yeah.
I do
Right.
not know. Right?
Yeah. No, exactly.
Is there a moment when you say that and they're like, well, why don't you look that up and come back and talk to us about it tomorrow?
Well, yeah, sometimes. Or like sometimes you can say, and I think people appreciate it when you're like, I don't know, but I'll go look it up, right? Or like
and then are you expected to talk about it at some point?
every once in a blue moon, kind of depends on who your person is.
Yeah.
Yeah.
They might tell you to look it up and then say you're going to present it tomorrow, and then that just doesn't happen.
Yeah. Yeah, that's true. I think the more old school people will like have you present about it. I've only had two attendings have us like present things that we didn't know. Both of them were on internal med.
Internal meds,
Yeah.
kind of a different beast. I get the feeling because it's very cerebral. I think.
It is cerebral.
Yeah.
Yeah.
Big thinkers over there.
Yeah, big thinkers. Neuro people, very quirky. Love them. They're fun.
Actually, yeah, neuro was fun.
They're like a quirky bunch.
Surprisingly. I don't know.
I feel like neuro's been one of the polarizing ones that I've heard about. Like people either love it or hate it.
No, but it's like neuro is way different than like neuro lectures. Like
True.
yeah.
Oh, yeah.
Like you don't have to know any parts of the brain
No.
in actual neuro.
Yeah, that's what I was talking to someone. I was like, we learned all about this like localization and everything, but I'm like, what do neurologists do like
Yeah.
in real life?
They're good at localization, but as a student, I can't say it came up much at all.
No,
Yeah.
they just like they
What is
manage
localization? What part of the brain you're?
Yeah,
if
so like
someone
if
has a
someone
stroke.
Oh,
Yeah.
I
Okay.
see.
Stroke week's a little different, but
yeah.
Well, someone told me that the ER is who's mostly localizing the stroke, because if somebody comes in and they're having a stroke, they
Oh.
have gone to the ED,
Mhm.
and the ED has done a CT scan on them or an MRI or
Yeah.
what have
like
you.
the stroke.
So like by the time they get to you on neuro,
They're already.
we already know what happened because
Yes.
somebody else had to do that
Yeah.
emergently before you got there.
Yeah.
Yeah.
Yeah, that's fair.
Yeah, and then what do? I don't know.
Yeah,
I haven't
I
got
know.
that far.
You just kind of continuously do neuro checks and make sure everything's okay and
Yeah.
talk with the family.
Yeah.
Lots
That's
of
the
neuro
issue
checks.
with strokes is you can't do a whole lot.
Mhm.
Yeah.
Yeah.
Yeah. You just kind of keep on watching.
I assume PT and OT
Mhm.
come in,
Mhm.
assuming
like,
things
you're
are
not
like
really
going
part of that.
okay.
Yeah.
Yeah, I mean, you can like put it in your plan, like, yeah, PT and OT should come see them, but
Oh,
like,
yeah.
you don't get to see the PT OT part of it, which is like kind of a bummer. So unless I guess you could specifically ask,
Yeah. Maybe.
Probably.
If you
I
have
feel
some
like
time.
yeah. What are they gonna do?
If
Say
you're
no?
not doing something, you can
Yeah.
just
Yes. Yeah, I think it's
check
more
in.
like you'd have to find the PTOT. Maybe on
Yeah.
rounds one day you could do. I don't know.
It's not like you can look up the schedule for this patient and
yeah,
Right.
they have their
no.
own
Yeah, they kind of PTOT just kind of shows up. I feel like I
Kind
don't
of
know.
like,
Maybe
yeah,
they have a
people
schedule.
just show
some
up.
sort of magic happens.
Yeah.
A miracle occurs.
Just like, oh, PT's there. Oh, they are.
it's time.
Okay. Yeah, but that is actually a really good plan. Pearl is PTOT. Just say that in your presentation. Be like, oh, PTOT should go see the patient.
Yeah.
And they'll be like, oh, wow.
I don't mind that at all. Yeah.
One of the transitions lectures this week dealt with the kinds of things patients will say that aren't cool and how to deal with those. And I'm talking about like, things like, you foreign students should go back to your country and I don't know, microaggressions and basically very, sort of inappropriate things that patients might say. Did that happen to you guys?
Well, Dave, as a white straight woman, I can not say that specific thing happened to me.
Okay.
However, I think that it's very common to have like your classic old dude be like, "Come here, sweetie," or like,
Right.
which is
Yeah.
sort
That's
of,
probably the more common thing that people that happens. Not like
Well-
outright.
Again, I can't say for sure, right? I've never seen it happen, like that kind of thing happen. I'm not saying that it's not happening though, because like,
Well, you can't
I
really
haven't.
testify. Yeah.
right, yeah. And I haven't seen it happen like with any of our like residents or like co-students either. But yeah, I think it's pretty common for, your classic like old dude to kind of be like, "Hey, sweetie," like, or like, "Oh, you brought the pretty ones today," or like, and the truth is like,
What are you gonna do?
in my opinion, like, who's that really hurting?
Okay.
It just doesn't really bother me, but it might bother you. And if it bothers you, that's okay. But that was not a fight that I was gonna like.
Yeah.
I don't know.
I will say
Thanks
we
for the
had
compliment.
we had one patient that the team knew was kind of like this, and so the attending just went and saw him by herself. And there was one time and she was a shorter lady of Asian descent, and she walked into the room by herself, closed the door, and came out like 3 seconds later and was like, yeah, I'm not doing that today. And so, like, honestly, I think that's okay sometimes. If it's really bad, just be like, yeah, no, I'll see you later. Someone else can.
Yeah, they also made a big deal out of saying that, this is probably going to happen. We still, sort of are obligated to take care of people, even if they're annoying. But as a rule, you're also basically allowed to be like, I need somebody else's help with this person.
Exactly.
Yeah,
Or like,
definitely.
I'm going to come back in an hour and like maybe they'll be better, or
Maybe
we can
they'll
talk
have
about it or
changed.
something, or I'll have
Yeah.
calmed down. I don't know.
And the other thing they talked about, as I recall, was, these people are here sort of in the hospital, sort of not always at their best. They're hurting, or they're,
Yeah.
anxious or whatever. And so you kind of got to, at least in your own head, cut them a little slack, I guess. I don't know. How does that
I guess I
track?
worked at a pharmacy before I came here, and I always found it a lot easier to separate things people say to me at the pharmacy from things people say to me not at the pharmacy, because they are having probably the worst day of their lives. Maybe not that specific day, like maybe that day already happened, but they're generally not coming to you because they're alive and well and everything is hunky-dory in their life. So like what they say there is probably not about me. And if I've called the insurance and run the coupon and like made sure it's the right pills in the bottle, I've done what I can do to help them with that. And so what they say to me about whatever the backstory is on that is not about me, versus like in real life, there's a good chance that it's probably more about me. So I generally find it easier to like separate those two things, and I'm hoping that it'll be the same thing
Yeah.
in the hospital.
Yeah.
Yeah, I used to be like a patient sitter, so I sat with a lot of people who were like having like acute psychiatric problems or, things like that, or older patients with dementia. So it's like,
They did mention that it was psych that would often.
yeah, and it's like, I've had food trays thrown at me. I've had people yell at me. So like, it doesn't really phase me. I'm just like, oh.
Yeah.
And then when you sit with them for a whole shift, it's like, then maybe a couple hours later, they're like your best friend. So like, I feel like now I'll just be like, okay, well, this isn't what they're like all the time. And, they're just having a bad
Yeah.
time. Yeah.
That's a good point.
Yeah.
And I do think there's a gradient between like, no, I don't want some random old man to call me sweetie, but like, I'm not in physical harm. I'm going to be okay if they call me sweetie, even if it's disrespectful, versus if somebody throws a lunch tray at me. That becomes a little bit more of a situation where it's not okay in any scenario, versus it's not okay to call random people sweetie, but
How do we feel about scrumpadumps?
What?
I don't know what that is.
Is that a type of like
I'm like, I see it. I'm like, hey, scrumpadumps, I'm here. I'm sure you're here to examine me.
I think I would knock them down a couple points on like their mental status
Yeah, it's
exam
a-
if they came out with scrumpadumps.
Dave, is that a real
Writing
word?
that one off.
You make that up.
It's a word from my past that was made up. Yeah.
Not alert or oriented.
Yeah.
Most of the stuff you guys are like, I'm still back on the paper. I'm sorry.
And that
Patient is making up words and calling me them.
that might warrant
It
a
was-
cognitive eval.
Yeah.
It was a term of endearment that some friends and I used every once in a while on each other. But I don't know. Whatever.
Did you make it up?
I don't know who made it. I'm pretty sure it wasn't me.
That was really kind of like a kind way to say that.
Did you? All right.
Oh.
Okay. So pre-clinical med school is hard. We know that. Clinical clerkships are hard in new ways, I think, and it's important to find new ways to make sure you're taking care of yourselves. But it seems to me that you're in some ways busier in clinical clerkships than you were in didactics. At least you're sort of expected to be certain places. I don't know. You know what I'm trying to say? Like, are you busier, do you think, overall in clerkships than in preclinical courses?
You have less control over your time.
Did you have a problem like figuring out how to study, bathe, eat, clean yourself, clean your house, be with your families? Did you have trouble finding time for that, or?
I didn't. I mean, I guess I didn't think it was much worse than preclinicals for me. It's definitely different. So I think that's kind of something to keep in mind is like during the weeks, it kind of are working a 9 to 5 a lot of the time. So it's like you do that and then you might have to study afterwards. And so I think it just maybe takes a little bit more planning is I guess what I'm saying. Because like Fallon said, you do have less control over your schedule. And so it just takes a little bit of planning ahead. But I think if you do that and you're like, you know, a good steward with your time, I don't foresee any like terrible issues with you know, getting food for the week or like, you know, finding time to exercise or do your hobbies. I think you can fit it in if you know, make time for it.
And like, it will never be perfect, but you'll like, you know, you'll just have some weeks that you're like, I screwed it up this week. And then you'll have some weeks where you'll be like, I did such a good job this week. And like, you know, and then there will be some weeks in between. I think the biggest thing that helped me was maximizing my time while I was in the hospital. So like, I just tried to do all my work stuff that was like within reason at the hospital. So like all my studying. And then when I was home, I was just like home. Unless it was before a test. And then.
Yeah, we haven't talked about shelf exams or things like that very much. Shelf exams, if you're not familiar, these are the exams that are usually given at the end of a clerkship to sort of assess your knowledge. And I think you can get all of the great evaluations and great comments. But if you screw up in your shelf exam, then that's, kind of a problem. You might have to retake the shelf exam or, like it's not like the end of the world. I think it happens. It's not
the end of the world, but
Right.
it is stressful to like have to deal with.
Yeah. It's just another thing that kind of sucks.
Yeah. And kind of going back to the schedule, like the week of a shelf exam is kind of akin to the week of like a big preclinical test. Like, yeah, you might not have as much time that week to do things you like to do, but I don't think that's much different, I guess, than what you guys have already gone through necessarily as a rising core year student. But
It's just instead of Anki, you have UWorld now.
yes.
Use your UWorld.
Yeah.
I remember specifically that you wanted to make sure to address certain questions.
The first one is, what do you do with your hair during core year?
So this is a thing, like appearance. Like we've had questions in the past about things like tattoos and hairstyles and things like that. Which I don't know if that's exactly what Zach was talking about.
Well, he said that his hair is.
This is
the
another Zach.
longest
This is
it's
Zach
ever been.
Grissom.
Third Zach.
Third Zach.
Which I know all of these Zachs actually.
Oh, yeah,
So
okay.
how about
There you
that?
go.
I
There you
keep
go.
them straight in my head. Yeah.
So yeah, Zach specifically, his concern was that his hair has been the longest it's ever been. And so like basically what do you do with it? Highly suggest don't keep it down. That's like a good way to get it in your face and patients' faces and patients' mouths.
Ew.
Yeah, right?
Okay.
It's like, well, if it's long, right?
Yeah.
Claw clip. That's the move. I love a good claw clip, especially because I have an aggressive hairline. Secondly, yeah, mostly just the claw clip. I feel like the claw clip is like, it's awesome.
Okay.
Claw clip all day, every day. And cute earrings, but not hoops while you're on psych, at least.
Oh,
is what I
yeah.
was told. So
Yeah. There were some male residents with long hair too. Like it's definitely people do it
Things
as
have-
long as you're.
People used to be very concerned about tattoos.
Yeah.
I think
And
some of
that's
our
not
residents are
really a
yatted.
thing
That's
anymore.
not a thing
Yeah.
for
Oh,
our
yeah.
generation.
No.
Yeah.
Not really. Yeah.
On the hair, Zach was not asking me this question, but like dry shampoo is really just a lifesaver if you're like
Oh.
moving out and about for a very long time. And you can buy like the little mini bottles, so it just fits in your backpack. Boys can use it. I'll out my husband. We used to have to go on trips for band with like a high school, and it was like a 36-hour road trip, and you just like buy your little bottle and you spray it in your hair and you like shake it through and you brush it and your hair.
We should be clear. Your husband, the band teacher, not
Yes.
your husband, the band student.
Yes,
the
my
high school
husband,
band.
the band teacher. We did both go on band trips in high school separately at our
Sure,
own
sure,
high
sure.
schools.
That's
We
not
did not
what
know
we're
each
talking
other at
about
the
here.
time. My husband, the high school band teacher, has used dry shampoo and very much likes it in situations like these. So if you are having a 16-hour day at the hospital, you'd have to buy like the unscented because we aren't supposed to be like fragrant.
Oh, yeah.
So I guess like watch for that. But
That's fair.
a hot tip.
I love that.
What if you're naturally fragrant?
Let's not.
A good or bad fragrance?
Yeah.
I don't think anybody's naturally
Hard for me
good
to. Hard for me to. Well, I mean. Well, let's not get into it. Okay.
Sorry, I have one more hot tip. Not about hair, but just about body care in general. Do keep a travel toothpaste and a travel toothbrush in a Ziploc baggie. Like you just never know. Keep Altoids. You just never know. And keep like little alcohol swabs because you never know when you're going to have stinky armpits.
Yeah.
Oh, that's what I saw that on your list
Yeah.
of things, and I was like, "What am I swabbing my stethoscope?"
Those two. But like you can use them for anything.
I was gonna say I just love having alcohol pads because like, phone too. Sometimes
Oh,
if
yeah.
you're like in the room and I don't know, stuff happens.
Yeah.
Like I don't know, it's just nice to have.
Oh, that's something I.
Hey,
Hadn't
medicine's
imagined
gross.
before. Yeah,
you
yeah.
gotta
Yeah.
get.
If
are
you're
dealing
ever
with
with
bodies.
a patient
Yeah.
that is vomiting, wash your hands like with the wash, like in the sink. Do not wash your hands with like the whatever that stuff is. You know,
Hand
The
sanitizer.
hand
sanitizer.
Mm.
Because things like norovirus are not easily killed by hand sanitizer. They just can only be washed off. So.
And C. diff.
And
Sports.
There we go.
That's what was a high yield during transition week.
How often did you wear your white coat? Like, we make a big deal out of it. We have this whole ceremony when you first get here, and then you don't wear it for 18 months, and then I don't know. Have you been using it since
On
you went through?
surgery.
Yeah.
Yeah,
Yeah.
I almost never wore it. Yeah, even on surgery, you have to wear it to like the conferences
Yeah.
that they do,
So,
and in clinic, you're supposed to.
but not
but
everybody does.
No, when I was there, none of the residents had it on. None of the attendings, at least on some of the services I was on, and so I was like, oh well,
But like nobody else cares about your white coat.
yeah,
I don't think. And
Usually
some
not.
people specifically say, do not bring your white coat.
true.
I think literally the only one that I had it for was surgery.
Okay. Interesting.
Yeah.
Interesting. What's the best way to think about grades and evaluations in a way that doesn't disintegrate your self-worth? Like you're constantly being evaluated, and sometimes on things that seem like parts of your personality.
Mm-hmm.
At least that's what I would be a little nervous about.
Just get a better personality.
Wow. Wow.
Put it on the eval.
Yeah. This person needs a better personality.
Oh man.
Evals are tough sometimes, just because the vast majority of the time I think the evals will be totally fine and like everything's great. But there is occasions where you get an eval, usually from an attending, and it's like they write you good feedback, and then the percentage grade that you get is just not what you were hoping for, and you're like, what could I have done differently? And I don't exactly know where this comes from. I think part of it is maybe like
I know where
just
this comes from.
not familiar with the software. Partly, I don't know.
Or some people feel like nobody gets a perfect.
Yeah, and like if they're rating your clinical reasoning like a 80% or whatever, it's like, well, as a third year medical student, it's
That's pretty good.
probably like. But if you're rating me against my peers, like, are you rating me against my peers? Are you rating me against yourself? Like, where's the line? So it's kind of subjective in that way.
So fun fact, residents give better ratings than attendings do.
Yes.
Really?
And this is, I mean, there's probably a few different reasons for that. Among them, it could be that residents are more familiar, or they're closer to you guys in their trajectory, and so they have more sympathy for you at this time, whereas an attending is further along. They've been specifically, in some cases, educated on, what it means to give a certain rating. And so, yeah, they do tend to give more, I think, harsh evaluations that seem harsher. And I know there's actually, some efforts to sort of normalize that, which in my mind sounds like having the residents tone it down a little bit.
Interesting.
So I don't know. That's a thing that happens.
Yeah.
So that, I don't know.
I think probably your best move is just to like be enthusiastic about learning, and be a person, like be you, and don't try to be somebody that like you think they want you to be, or try to impress them or make other people look bad in like the goal of impressing somebody. Honestly, like nobody likes to try hard, so don't do that. Just be a normal person. I think like a lot of evals are like, could I imagine myself working with this person happily? And if I can do that, and like you've done all the things that you can do that like make it easy, then great. And if you're hard to be around, then you're probably going to get a harder eval.
Yeah, that's true. Most of the eval actually is like professionalism, and then like other just kind of more subjective things, like less about like what was your clinical knowledge skill. And so like those categories, if you are just yourself, you'll get good grades in.
Yeah.
So it's not something to be worried about. It's just like sometimes it can be frustrating.
I sometimes,
Especially when they're inconsistent, right? 'Cause
Yes.
sometimes they're, you'll get a good eval from one person, then you'll get a less good eval from another person, or they contradict each other,
Yeah.
and you're like, well, what am I supposed to take away from this?
Right, exactly.
Yeah.
Yeah.
Did you spend a lot of time thinking about like, this is what I'll take away from this evaluation, I'm going to discard the rest of this?
I honestly, the things I took away the most was when people gave me like verbal in-person feedback. Yeah.
Right.
yeah.
Sometimes the paper evals, like I would always look at them, but I wouldn't always necessarily like change what I'm doing based off of that. But a lot of people are good about verbal in-person feedback, and that's usually like way more helpful. At least I found.
Yeah.
Okay.
Yeah.
Well, we've been talking for a little while. Fallon and Zach, I want to give you guys the last words. Looking back, is there any difference between what you thought clerkships would be like versus what they are actually like?
I guess I thought that clerkships were going to be way scarier, and just like way harder, and just like really like nose to the grindstone, like you've just got to do this. I don't know where that saying comes from actually, now that I'm saying it, so I hope that it's not like a horrific saying. Anyway,
It came from Dave.
anywho,
Scrumpadump to the ground.
Scrumpadump to the grindstone. Anyway, and so I think the first rotation is sort of like just getting the hang of it, and that's why it's hard. The second rotation is like you're getting the hang of changing expectations. But by the third rotation, you're going to be fine. And like you're going to also find out that you've actually learned some stuff, which is very jarring.
Wait a minute, this med school thing works.
Right, exactly. And like you're gonna, but I think like for me, I second guessed myself, and I was like, oh, like I think I have a plan, and then I was like, you should not have a plan. Anyway, so like just trust that yes, the process does work. You are going to learn things, and by the end, you're gonna be like a confident bean. So yeah, I'm excited for you. It'll be good.
Yeah. I don't know that I had any like super rigid expectations going into core year. One thing I'll say is that the first half of core year for me was like hard, just because there was a lot of information that I was like, oh, whoa, I don't know a lot. There's a lot to learn. But then the second half of core year is a lot easier, at least I found. Like once you kind of get over that hump of like, okay, I've learned a lot of stuff. I know what the expectations of me are. I know how to operate in like a clinic and an inpatient. The second half of core year is pretty fun, and you can kind of just like focus on things you're interested in, learn the details of the stuff you need to learn, and just kind of, I don't know. So get through the first half,
Yeah,
and the second half should be better.
it's okay if you feel burnt out too.
Yes.
Like, that's pretty normal.
Yeah. probably will.
just let yourself just lay or just do something that makes you happy. I was a big lay down person.
You're a horizontal.
I was a horizontal girly. Yeah.
Shortcoats, if you have something you want to say about today's show, something you want to hear about someday, a question you have, go to theshortcoat.com/tell us, send us a message. Otherwise, Fallon, thanks so much for putting together this discussion today.
Dave, this was like the honor of my life. Thanks.
Oh, Zach, Alexis, Samantha, thanks for kicking it with us today.
Absolutely.
And Alexis and Samantha, go kick some ass on clinicals, all right? Do it for
Yeah.
me. If not for
Dave.
yourself. For Dave.
And
Until
our
next
bingo
time.
board.
Until next time, I'm Dave Etler saying don't let the bastards get you down. Say bye, everybody.
Bye.
Bye.